We'll just wait for a few seconds. We already have a good evening from the Philippines. From Maria. Hi, Maria. All right, I think we can start now. Welcome everyone to Health for the World International Grand Rounds. We are really honored to have a Grand Round speaker, Dr. Mark Foka. For those of you who are joining this session for the first time, Health for the World is a nonprofit organization based in California, promoting health worldwide using education, technology, and humanitarian assistance in 122 countries. I'm Dr. Bhavya Rehani. I'm the co-founder and president of Health for the World. We also have our co-founders of Health for the World, Dr. Bill Dillon and Dr. Ankur Parija here, and Venkat, who's our team member. This week was MLK Day, and I wanted to start with one of his writings as a Morehouse College student in 1947, which says, education must enable one to sift and weight evidence, to discern the true from the false, the real from the unreal, and facts from the fiction. Throughout the pandemic, our aim has to disseminate reliable information from extremely well-known experts. So we are really honored to have Dr. Foka today. As you know, we have a series of Omicron talks. This week it's Dr. Mark Foka. Next week we'll have a South African panel of experts. We'll be talking about the Omicron experience in South Africa. As always, please feel free to enter your name, the country where you're from, in the chat box, and the question and answers which you have. Dr. Foka's talk is for about approximately 30 minutes, so we do have time for question and answers today. So I'll start with introduction for Dr. Foka. Dr. Mark Foka is Associate Professor of Pediatrics at Albert Einstein College of Medicine. Dr. Foka did his postgraduate training in 1995 with a 3-year internship and residency at Babies and Children's Hospital at Columbia University. He then completed a fellowship in pediatric infectious diseases at Columbia University in 2001. Dr. Foka's work has been shared at national invited lectures and international expert panels and published in a number of peer-reviewed journals, books, and abstracts. Dr. Foka has been named one of the Castle Connolly's top doctors in pediatric infectious diseases from 2014 to 2020. Thank you so much, Mark, for joining us, and you can start whenever you're ready.
Thank you. Thank you for that kind introduction. Good day, everybody. I hope you're all well. I'm going to try today to give you a little bit of an idea of the rapidity of the Omicron variant and its effects on pediatric patients. And so I'm going to start with a series of graphs, the first being from South Africa, and you're going to get much more information from them next week. But you can see that these are the 4 peaks corresponding to their beta variant, the Delta variant, original lineages, and in the pink, the Omicron variant. And what you can see is while the ultimate number of cases was quite similar over several of these waves, the rapidity with which the Omicron variant showed itself was much more rapid than it was with either of the other two. You can see a much wider base here on each one and a longer tail. Now this is only data from up through December, so we don't see the drop in cases, and they'll probably show you some of that data next week, but their cases have dropped as dramatically as I'll show you in some other spots. This is my home state, New Jersey. It's about the size of Israel, with a population of 9 million. If it were a country, it would be the 5th most densely populated country in the world. And so we were quite affected by the original wave. This is New York Times data on the left. And this is the original wave of infections that we saw in the spring of 2020. This is over the winter, last winter. This is our Delta wave, which was fairly small, and I believe probably that's small because of the high rate of vaccination in the state. And this is the Omicron wave. You can see many more cases over a very short period of time, and now rapidly declining. I believe our peak was in the beginning of January, and we've dropped quite nicely since then. But you can see the number of cases, at least 4, 5, 6 times more with the Omicron variant, despite being highly vaccinated. These two graphs show hospitalizations. So again, Omicron variant hospitalizations much higher than any of the other peaks. And mortality is reaching what we saw with last winter's wave, but not nearly what we had during the spring of 2020. So lots of hospitalizations, relatively short admissions for most patients, increases in mortality, but not nearly what we saw earlier on. This is some nice data from the UK, and it's color-coded by variant wave. And this is pediatric cases, hospital admissions in the UK by wave. And you can see the original variant in blue, the alpha variant in the pinkish color, Delta in yellow, and Omicron in orange. And you can see the number of hospitalizations, very rapid. This is a 3-week span, and there were as many admissions in pediatric patients in this 3-week span as there were during the whole original variant wave. So very rapid rise in cases and hospitalizations. This is data from the CDC, but nicely summarized by The Economist. So this is the effect of Omicron on different age groups, and you can see the pediatric age groups are in the blue colors, 0 to 4 and 5 to 17. Many cases, lots of cases compared to other age groups. And hospitalizations, while they're increased for the 5 to 17 group, they're much more heavily skewed towards the 0 to 4. So 0 to 4s are being admitted more frequently in the United States, and we'll get into some of the severity and presentations. So that's sort of the general outlook. So Omicron was first reported to the World Health Organization on November 24th of 2021. So it's only been about 2 months, and it's pretty rapidly spread across the globe. There are approximately 50 mutations compared to the original strain, most in the spike protein, which may have to do with the ability of this particular variant to adhere to the ACE2 receptor. Now, when we look at different variants, if you talk about the Delta variant, which we've been dealing with for most of the year, this was 100% more transmissible than the original strain, and in some ways similar to varicella. So the R naught, as you've probably heard many times before, is the number of people that can be infected by a single individual. And so for varicella, it's somewhere between 7 and 8, and that was the approximation of the Delta variant. Omicron is 4 to 5 times as transmissible as Delta, and has an R naught that we believe is similar to measles, somewhere in the range of 18. So, and measles is one of the most highly transmissible viral agents that we know of. So Omicron rivals anything we've seen in the past in terms of transmissibility. So this is a very nice study that was done in Norway. Some of you may have seen it. This was the result of a Christmas party at a single company. They rented out a room, so it was a private party. There were about 170 individuals from this particular company who attended. All of the attendees were fully vaccinated, meaning they had had 2 mRNAs vaccines or a J&J vaccine. And all of the attendees had to have tested negative with a rapid test within 2 days before the party. And you can see here is the Christmas party. And obviously it's not perfect because these people were seeing each other at work. So there were some cases that were symptomatic prior to the event. But this is the day of the Christmas party. This is the result of the transmission event. There were somewhere north of 60 cases. This particular patient, we believe, is the patient 0. This person had traveled to South Africa just before returning home to Norway and attending to the party. And what this epidemic curve really shows is that the incubation period for the Omicron variant is likely about 3 days, whereas the original strain, it was 5 to 6 days, and for Delta, it was believed to be about 4 days. So shorter incubation period. And also, these are all breakthrough cases. These are all people who were vaccinated and tested negative prior to the party. So highly transmissible, even in vaccinated individuals, and a shorter incubation period, which makes epidemic control a little bit more difficult. So what are the symptoms? In older children and adults, symptoms have generally been more mild. A scratchy, sore throat, nasal congestion, low back pain, which I can attest to. My daughter had a breakthrough case after full vaccination and had pretty severe lower back pain. Ear pain has also been described. Much less loss of taste and smell than in previous waves, and less shortness of breath on the whole. In terms of hospitalizations, for the Delta wave, it was about 15%. So if you had 100 cases, you would get 15 hospitalizations. And for Omicron, it's been about 5%. But since it's more transmissible and there are more cases, these are about equivalent. So 500 cases of Omicron would lead to 25 hospitalizations, even though the hospitalization rate is lower. And I think this is a very important point. The number of cases that we're seeing, as you saw with the graphs, far outstrips anything we've seen before. And even though it's less severe in general, and fewer people are being admitted to the hospital, there's still going to be more patients admitted because of the number of cases that we're seeing. Okay, and I'll show you some data later about vaccination status and admissions. And then, as with all variants, the risk of transmission is less when you're outdoors than when you're indoors. So, pathogenesis and why this variant might be a little milder than previous variants. So the whole slide, I don't expect people to really focus on. It's mostly this area here, the attachment of the coronavirus to the ACE2 receptor. And then for previous variants of concern, this enzyme TMRPSS2 was important for cleaving the attachment site and allowing viral entry into the cell. And it just so happens that this particular enzyme is highly expressed in lower airways in the alveoli of the lungs, as is the ACE2 receptor. But this was a very nice in vitro study that was done comparing Delta entry into cells versus Omicron entry into cells. And they used 3 different cell lines. The Vero cell line does not express the enzyme TMPRSS2. So they transfected Vero cells in one experiment with that enzyme so that it was expressed. And then they used another cell line that has high expression of the TMPR enzyme. And what you can see here is in the middle graph, with the Vero cell line that does not have TMPR, that entry into the cells is about equivalent. Early on, it might be slightly greater for the Delta variant, but over time, they both enter the cell about the same. If you look at the cells that naturally express high levels of the TMPR enzyme, the Delta variant gets into these cells at a much greater rate. than does the Omicron variant. And when you use the Vero cell line with the transfected enzyme, you also see a much higher rate of entry into the cell for the Delta variant than you do for Omicron. So it turns out that that it's believed that the Omicron variant does not use this enzyme as effectively, or is not as sensitive to this enzyme, and so it's mostly entering the cell through endocytosis rather than an active process of using this enzyme and getting into the cell. So it may be less efficient at getting into cells and less efficient at getting into cells that express this enzyme in particular. And so we know that there are more of this enzyme in the alveoli, and this may be why we're not seeing as much lower airway disease with this particular variant as compared to the others. And this is why, maybe why, the younger children now are more affected, because it's mostly an upper airway disease. So we're seeing far more croup and bronchiolitis and febrile seizures in the very young infants. Also more fever workups in children 90 days or under. There have been reports of tachyarrhythmias and bradycardia with this variant. And there are emerging reports of the syndrome of post-infectious cerebellar ataxia that have been put up on the Emerging Infections Network. And these are just, I just saw this report yesterday, as a matter of fact. So we had a case at Montefiore, a 9-year-old, I believe, who had a symptomatic SARS-CoV-2 infection several weeks before presenting with ataxia. So again, a little bit of data from South Africa in terms of severity. These are the previous waves in the dashed lines. This is the Omicron wave. The solid line is mortality. And so you can see for the Delta wave, mortality was greatest in South Africa. And here for the Omicron wave, mortality was quite low. So they saw much less severe disease in terms of mortality than they had in previous waves. And I think, this has been shown in the UK as well. From New Jersey, so I can give you an idea of vaccination status and the number of cases we've seen and the number of deaths. So this data is reported for the month basically of December 6th through January 2nd. There were 363,000 cases of SARS-CoV-2 in New Jersey, resulting in 11,000 hospitalizations and 600 deaths. Of those, 3.86 million people had received either one J&J or 2 mRNAs, so it's considered to be fully vaccinated. There were 113,000 breakthrough cases, so about a third of the cases that were documented over this month were breakthrough cases, but that only resulted in 800, almost 900 hospitalizations and only 2 deaths. And then for the 2.3 million people who had booster vaccines, there were 19,000 breakthrough cases, 161 hospitalizations, and 2 deaths. So vaccination, while not preventing individuals from getting breakthrough disease at as great a rate as we've seen with other variants, has resulted in far reduced hospitalizations and mortality compared to those who are unvaccinated. So the unvaccinated make up the largest portion of hospitalizations and deaths, at least in New Jersey. So now some data more on pediatrics and admissions. So this is a large cohort study, a study looking at electronic medical records from across the United States. And this was done by a group at the Cleveland Clinic. And this original study, both of the studies I'm going to show are on medRx and have not been peer reviewed yet, but they are quite interesting. So they had compared the Omicron variant cohort to a Delta variant cohort. And in this particular paper, it was the Omicron variant was December 15th to the 24th, and the Delta cohort was the beginning of September to the middle of October. And they had to propensity match because there were differences in age and severity. So they matched the Omicron patients, the 14,000 Omicron patients, to 14,000 Delta patients to look at these particular variables: ED visits, hospitalizations, ICU admission, and mechanical ventilation. And what they found for the entire cohort was that for all of those variables, patients with Omicron were less likely to meet those conditions. So less likely to go to the ED, less likely to be hospitalized, less likely to be in the ICU, and less likely to be mechanically ventilated. When they compared two different Delta cohorts, so they went, Delta cohort 1 was the beginning of September to the middle of October, and then they looked at the middle of October to the middle of November to the end of November, just to see if there were differences in admissions and ED visits for the Delta cohorts. They really didn't see too much in the way of differences between these two Delta phases, as might be expected. When they looked by age, and I'm sorry, this may be a little bit difficult to see. The top line is the 0 to 4 age group. They were much less likely to go to the emergency department, as was 5 to 11s and 12 to 17s. When you looked at hospitalization, excuse me, 0 to 4 also less likely to be admitted to the hospital, whereas the 5 to 17-year-olds, there was no difference. When you compared Delta cohorts, there was no difference between ED visits and hospitalizations. And then they looked at particularly at children under 5. And this cohort was slightly later. It was into the beginning of January. And so it had 7,100 or 7,200 patients with Omicron versus 7,200 with the Delta variant. And as you can see, in the 0 to 5 age group, they were less likely to meet any of the criteria. And if you looked at the Delta cohort, again, there was no difference. So it appears that, yes, the Omicron variant is less severe. There are fewer ED visits, hospitalizations, fewer admissions to the ICU, and less mechanical ventilation for most age groups, except for the 5 to 17, who are, the hospitalization rate is no different. But the fact of the matter is, we're seeing so much more disease that we're still seeing a large number of hospitalized patients. If this were equivalent to Delta in terms of severity, we'd be in a much different situation than we are right now, even though we're being strained pretty close to the limit in some places. So in terms of other outcomes in pediatric patients, these next two studies I'm going to describe are were done prior to the Omicron variant, but I think they're very instructive. This is a prospective study worldwide. There were 8 or 9 sites around the globe who enrolled patients prospectively, pediatric patients less than 18 years of age, who were seen in their emergency departments. And they enrolled over 10,000 patients because they wanted to have a SARS-CoV-2 negative comparison group. But this study looked at only the 3,200 patients who were SARS-CoV-2 positive. So when they evaluated them in the ED, 2,300 or so were discharged from the emergency department, and 685 were admitted to the hospital, with 91 being admitted directly to the ICU. So that's about 13%. If you look at those who were discharged, they were much less likely to return to the emergency department for further care. There was a cohort that did come back resulting in about 50 hospitalizations out of this 2,500 patients. And only 12 of those had severe outcomes, which was considered ICU admission, pressor support, or some form of more invasive ventilation, and there were no deaths. So if you were seen in the emergency department and discharged, your likelihood of doing well was great. If you were admitted, it was a little bit different. 541 of them were discharged and did not return back. There were 77 who did return, of which 27 were re-hospitalized. So that's a rehospitalization rate of about 35%. There were 96 had severe disease, so that's about 14% compared to 0.5% in the ED discharge group, and there were 4 deaths. So if you were admitted, there was a higher likelihood of having to return for care and a higher likelihood of having severe complications. And now when they looked at risk factors, I won't go over risk factors by country. Some countries did better than others. It looked like more severe outcomes were seen in the older age groups, so 5 and above as compared to 5 and below. If you had a chronic medical condition, you were more likely to have a severe outcome. If you had a previous episode of pneumonia, you were more likely to have a severe outcome. Asthma was not a risk factor for severe disease. And if you had symptoms for 4 to 7 days before presenting to the emergency department, you were more likely to have a severe outcome. So longer duration of symptoms, older age, chronic condition, and a previous episode of pneumonia were all associated with a higher risk of complications. All right. Now, what about infants? So we've been seeing a lot of infants for 90 days and under for fever workups. And so this particular study, also done before the Omicron surge, was a single center study done in Montreal. And it was looking at pre-pandemic evaluations for fever and during the pandemic. And the takeaway from this particular slide is that the pre-pandemic, they were seeing about 1,000 patients a month for fever workups. And during the pandemic, which in this particular study was March 2020 to March of 2021, they saw about 1/3 of those patients, a number of patients. So far fewer patients presenting to their emergency department with fever than they had previously seen. If they were admitted, their hospitalization stay was no different. And what you can see from this slide, if you look here at the number of patients who were SARS-CoV-2 positive, there were 311 patients who had SARS-CoV-2 testing done during the pandemic versus 0 early on and 2 in the middle period here, of which 20 were positive. So that's about 6% of their patients that were admitted for fever workups. And what's also interesting is that they were more likely to have serious or invasive bacterial infections than the previous 2 cohorts. So here, serious bacterial infection, which was considered urinary tract infection, bacteremia, or meningitis, they had a rate of about 20%, whereas it was about 10% in the previous 2 periods. And this really lines up with the number of serious bacterial infections that we generally see in infants under 90 days of age. So about twice as many patients with serious bacterial infections and 4 times as many with invasive bacterial infections, which were considered bacteremia or meningitis. So they had higher rates of infection in general, bacterial infection in general, and about 6% of their patients had SARS-CoV-2. And when you look at the infants who were SARS-CoV-2 positive and also had an infection, it was about 5%. And the numbers are small, but this certainly lines up with what we see for RSV, let's say, is that about 5% of infants who are RSV positive when they present to the emergency department, but are in the age range for a fever workup, have a serious bacterial infection. And this was a UTI, which is also the most common serious bacterial infection in infants with RSV. So the take-home message here is it appears that fewer infants were presenting during the epidemic period, but of those infants, more of them had serious bacterial infections. And if you had SARS-CoV-2, you had about a 5% chance of having a serious bacterial infection, which was most likely going to be a urinary tract infection. So don't ignore fever in an infant 90 days or less. If they have SARS-CoV-2, they can still have serious bacterial infections. Now, what does Omicron mean for multisystem inflammatory syndrome in children? This is data reported to the CDC for the United States, and these are the different waves of infection in the United States. And you can see this is the Omicron wave here. This data only goes to the end of December, but you can see that here is the peak of MIS-C for the Delta wave, and we have not yet seen a peak in cases of MIS-C with the Omicron variant. We don't know if Omicron variant is going to lead to many cases of MIS-C. There were fewer MIS-C cases in comparison to SARS-CoV-2 case rates for the Delta variant than there were for other variants seen previously. And so there is some idea that maybe the Omicron variant will not be as severe in terms of children developing MIS-C, but we have yet to see that data. I can tell you that we saw our first case of MIS-C at Montefiore this week, and that is about 7 weeks into the Omicron wave, and generally corresponds with what we've seen with MIS-C waves in the past. So we'll see what the next several weeks bring as cases of SARS-CoV-2 drop. This is just showing you the age distribution of cases of MIS-C. And so remember, the cases are more likely to be in those in ages 5 and older than they are in those 5 and under. So even though we're seeing more admissions for SARS-CoV-2 in the 5 and under group, it's possible that we won't see as many cases of MIS-C. It's also possible we won't see as many cases in this older group because these children, at least in the United States, can get vaccinated. And the next slide, I'm going to show you some data about that. So how does vaccination do when it comes to preventing MIS-C? So this is a study done by the CDC looking at 102 cases of MIS-C just prior to the Omicron wave. This was over the summer. So this was Delta wave cases of MIS-C. There were 102 that they looked at. 97 of those 102 cases were in unvaccinated children. Only 5 were in fully vaccinated children, meaning they had received 2 doses and it had been at least 28 days since their vaccine before they were hospitalized. And you can see that of those 5 cases, only 1 went to the ICU, and there were no critically ill patients. None were mechanically ventilated and required vasoactive support or ECMO, as compared to quite high numbers of unvaccinated patients. So it appears that vaccination or full vaccination with 2 vaccines, at 2 mRNA vaccines, is about 91% protective against developing MIS-C. And so what are the take-home points for Omicron? It definitely appears to be more infectious than previous variants. It has a shorter incubation period with generally milder symptoms, but the unvaccinated can still get quite ill. So the lesson there is to vaccinate, vaccinate, vaccinate. The rates of MIS-C are unknown, and we'll see over the next few weeks. I haven't seen reports from the UK, so I don't know what cases of MIS-C are like in the UK. They were a few weeks ahead of us in terms of cases. and children under 5 are being admitted with relatively standard under 5 viral infection complications, but they're generally doing quite well. And so I'll end it there and take any questions that you have.
Thanks, Mark, for this excellent talk. This was extremely helpful and, with really good data. So I really appreciate it. We do have some questions. The first question is, how long does
being admitted with relatively standard under 5 viral infection complications, but they're generally doing quite well. And so I'll end it there and take any questions that you have.
So the question. Thanks, Mark, for this excellent. We do have some questions. Okay, there we go. It's better now. All right. The YouTube live is going on simultaneously. So I think that's why we are getting 2 feeds. Okay. And so we'll be addressing questions both from the YouTube live and the Zoom. Okay. So the first question is, how long does it take to get a negative test in a home rapid kit for a child who's less than 5 years for Omicron?
That's a great question. I'm going to say that I haven't seen any data specifically on under 5 age groups. I can tell you anecdotal data from my own family in a fully vaccinated individual who acquired breakthrough infection. It took 3 days for him to become antigen negative. But there are vaccinated individuals who are taking 7 or 8 days to become antigen negative. And so it's really quite variable and may depend somewhat on immunity and age. So I would assume that younger patients are going to handle viral upper respiratory infections much better than somebody my age. And so they may become undetectable by rapid test more quickly, but I don't know specifically if that's true.
All right, thank you. And then there's a question about how do you evaluate the potential risk of the COVID mRNA vaccine in kids? So, if there are there any potential risks of the vaccine? I think that's a question globally, which we get, where the mRNA vaccine is available,
Yeah, so the data, I have not seen the data on under 5s yet because it hasn't been sent to the FDA. But the data from the 5 and up age groups are very similar to data for adults. And in fact, in some children, there are fewer vaccine side effects. So the standard side effects of sore arm, fever, and some malaise are fairly common after vaccination. The more severe complications like Guillain-Barré or anaphylaxis have not been reported in any great numbers in children, nor have, to my knowledge, the episodes of the clotting with thrombocytopenia that we've seen in some adults who've received the J&J vaccine.
Right.
So I think in general, side effects have been much milder in children, and efficacy has been similar to adult studies.
Right, and obviously the benefit of the vaccination is so high, so it's
far outweighs any
the risks. Absolutely. Risk. And then there's a question about have you seen myocarditis and left ventricular dilatation in children with COVID? It could be Omicron or Delta.
So yes, we certainly do see myocarditis in children with acute COVID and with MIS-C as well. So there is a lot of discussion about myocarditis after vaccination, but the rates of myocarditis are far lower in children after vaccine than they are in those who acquire a wild type infection. And their course tends to be much shorter. Most of those children were only admitted for a couple of days.
All right. Yeah, that makes sense. And there's a question about how do you compare the seasonal flu to Omicron in kids?
So just from data in the United States, generally speaking, seasonal flu, there are about 50 to 100 deaths in children in the United States every year from seasonal flu. And there have been almost 1,000 deaths in children during the pandemic. So it's the mortality is much higher at this point. If Omicron is sort of a natural progression of this coronavirus into a milder disease, it may start to have a mortality that approximates influenza, but right now it's much higher than influenza.
Right, absolutely. And there's a question about, can you please provide the reference for the last table presented with the respect to that data? I'm interested to know the percentage of MIC patients with comorbidities in vaccinated versus not vaccinated.
Oh, sure. I can find it and send it to you, and you can distribute it.
Sure.
I'm not sure how much detail they go in terms of comorbidities, but yes, I can find that for you.
Okay, sure. And then Karen, I'll email it to you. Do you think Omicron variant presents GI symptoms? Because majority of my pediatric patients have to have diarrhea.
Yes, absolutely. I don't know if it's quite as frequent as it has been with previous variants of concern, but yes, it does present with diarrhea still.
Okay, all right. As far as prevention, there's a question on YouTube. How do you prevent kids from getting Omicron in less than 5, especially because there is no vaccine currently available? Any tips on that?
Yeah, so this is one of the trickier aspects of this particular wave because so many people are getting infected. I think the short answer is that the rest of the family, if they're age appropriate, should be immunized so that you're getting some ring immunity to that particular individual who's more susceptible. But it is quite difficult to keep children that age away from everyone else. And if if family members develop breakthrough infection,
Right.
It's doubly difficult. Masking with a good mask, an N95 or a KN95 at home, will help prevent some transmission within the household. But for very young children, that can be difficult, right? You can't be away from them for prolonged periods of time. They might come into bed with you at night. So it has been tough for families with young children at this point. But vaccination and wearing masks at home, if you have breakthrough disease, are the two best preventive measures I can think of.
Right. And for less than 2, because they cannot wear masks, I think the CDC guidelines, say no masks for less than 2 and no vaccinations for them. So I think any other prevention tips for less than 2 years age group, I think that would be a tough age group,
It's very tough. Many people have to go to work. They need to be in daycare.
Yeah.
It's hard to take them out of daycare
Right.
because of that. Because of working, and so it's extremely difficult. I don't have good answers. I'm sorry.
Yeah. I think that's a really tough one. Regarding the vaccines, parts of the world where it is available for older children, I think you already answered that about the side effects. I think the benefits outweigh the risk. As far as a vaccine regimen for children, for Johnson & Johnson and AstraZeneca, where it's available, rather than the mRNA vaccine, you would recommend the boosters, right, for the older children.
Yes, so we can boost in the United States. We're boosting 12 and up automatically. 5 to 11 people are getting boosted if they have conditions that put them at higher risk. So patients who are immunocompromised.
Right.
Get a third dose.
Right.
And when vaccine is approved for the under 5s, it looks like 2 to 4 year olds will need to get 3 vaccines.
Right.
As a standard regimen, and the under 2 are doing okay with 2.
Right. And I think you already answered this about the timeline for less than 5 years, maybe next couple of months.
I think in the next couple of months, yeah.
Right. And you mentioned the less enzyme, the TMPRS2 in the lower airways, and that might explain that the children have more upper respiratory tract infection rather than, lower respiratory tract. But have you seen ARDS with Omicron in the hospitalization in the children?
We have seen ARDS, but it's mostly in older children,
Okay.
preteen and teen. I've not seen ARDS in the under fives. Severe bronchiolitis requiring intubation, but not ARDS.
Right. And the cause for the question is what is the cause for hospitalization? I guess it must be oxygen therapy for bronchiolitis and for croup, right? What is the cause? Okay. Perfect. And then there's a question about what are the red flag symptoms and signs for bad prognosis?
That's a very good question. I don't know that anybody's really with this wave looked at prognostic factors. Earlier on, children who had BMIs greater than the 95th percentile generally did worse. And those with chronic medical conditions like neuromuscular disorders and hematology oncology patients. And I believe that's still fairly similar for the Omicron wave. And then, the data I showed was that chronic illness was a risk factor for progression. So those are patients you have to worry about.
All right, thank you. And then there's a comment, excellent lecture from Mexico. And then the question is, have you seen neonates getting Omicron from their mothers?
So the youngest patient I've seen is 2 weeks. And I don't believe we've seen much in the way of mother-to-child transmission, even with the Omicron variant. I will admit, though, that there are a large percentage of pregnant women are not vaccinated where I work. And so there are many deliveries of women who are COVID positive at the time of delivery. But I have not heard of mother-to-child transmission in that cohort. I presume the 2-week-old developed it after going home.
All right. And there's a question about home management for children with COVID-19 once they test positive and parents are managing at home. What are the danger signs to move them to the ER and act immediately?
So in general, for the under 5 age group and even younger, so the under 6-month age group, it's going to be obviously fever and tachypnea. Decreased feeding, the usual things that you might see with an infection in such a young age group. For the older group, it's going to be mostly tachypnea, right? Otherwise, it's going to be supportive care. Most of the older children will have a viral upper respiratory infection and do okay. And so the slightly younger ones will, because of the size of their airway, will obviously develop airway narrowing and croup.
Right.
But the older kids, it's mostly going to be tachypnea.
Do you recommend monitoring with pulse oximeter at home, the oxygen saturations, and if they fall below like 93 or 92, then move to the ER?
Yeah, so I do that with my immunosuppressed patients, definitely. And certainly if people are able to get an O2 sat monitor at home, it is a good tool to have in general for everybody, right? So yes, if they're available, I think those are good tools.
Right. As far as treatment, because of the mutation in RBD and NTD, there is resistance to some monoclonal antibodies for Omicron. Have you been using monoclonal antibodies for treatment in children?
So the only monoclonal we can use is sotrovimab. I'm not sure what everybody else calls it, but that retains activity against Omicron, but it's in very, very short supply.
Yep.
And I think we've given it to maybe 2 patients, both immunocompromised and slightly older. So it's not standard therapy.
Right, right. And Paxlovid, I think it's only for more than 12 years. Is that right?
That's correct. Over
Right.
12.
Some of the places in the world are using Remdesivir, and they want, the question is whether that is recommended for children,
Yeah. So we are using Remdesivir to try to prevent progression. So there was a study in adults, I believe it was published in the New England Journal, that looked at 3 days of Remdesivir in patients who were at risk for progression. And it prevented hospitalization in 90% of individuals who received Remdesivir for 3 days, which is about equivalent to sotrovimab, monoclonal antibody, or Paxlovid oral therapy. So yes, we have used a 3-day course of Remdesivir in children to try to prevent progression of disease.
Excellent. I think because it's available in different parts of the world, so that is good. As far as long COVID in children, any evidence of long COVID in children I know with Omicron it's too early, but with other variants,
It's very early for Omicron, but there's certainly evidence of long COVID in children with other variants. There's data out of the UK showing fairly high rates of long COVID. Now, whether that's lasts longer than 3 to 6 months, I'm not sure, but there certainly is data that long COVID is occurring in children, and we'll have to see with Omicron.
Yeah, there's a question about dealing with vaccine hesitancy. How do when you see unvaccinated children who are eligible for vaccines and there is some vaccine hesitancy, do you have tips of of dealing with that?
Yeah, it's one of the more difficult problems that we deal with. I think in some ways it has to come from other people that the families trust. So church groups, extended family. It's very difficult for somebody like me to go into a room and tout the benefits of vaccination to someone who's skeptical and have them change their mind. I think changing their mind is a more personal experience, and it probably has to come from people in their family who've gotten sick and recovered and can tell them how severe it can be, or who've been vaccinated themselves. And not that as healthcare professionals we wouldn't tout the benefits of the vaccine, but I think for many people at this point, our opinion is probably not going to be the one that sways them.
Right, right. And a related question to that, if a 12-year-old male has no comorbidities, does risk of vaccine complication, such as myocarditis, really outweigh the risk of severe infection and hospitalization?
So I would say yes, right? The rate of myocarditis in a 12-year-old is very, very small from vaccination, and vaccinating that individual, the benefits far outweigh the risks.
Right, and that's a very common question I get, from our global colleagues. I think there's a lot of concern for myocarditis, and thanks for answering that. So that's really important. Do you recommend giving antibiotics for symptomatic pediatric patients with sore throat and upper respiratory tract infection at all?
Not if it's just COVID related.
Right, right. With some another question, but with some in medical community believing that second dose of vaccine is recommended too close to the first, why have we not seen change in administration recommendations?
That's a very good question. There certainly are people who believe that the second dose should be given further out. And, as with any childhood vaccine, we give them several months apart. So there's no reason to believe that wouldn't be true for this vaccine as well. I think, the original impetus was just to try to get people vaccinated as quickly as possible. And I don't know when those recommendations are going to change.
Right.
Somebody's going to have to put together a good study showing that the immunity is better if you
Right.
wait 2 to 3 months.
Right. Then another common question, multiple questions about school and daycare. Any advice of protecting the children, who have to go to school and daycare, except the masks, anything else which can be done better?
Yeah, so school-age children, if you're able to, should be vaccinated, right? Anybody who's 5 and up should be vaccinated. They can wear masks, and many do without any difficulty. And all the staff need to be vaccinated and also wear masks. I think those are 2 very simple ways to keep children in school. If they're old enough, vaccinated, all the staff need to be vaccinated. They can wear masks. There should be good ventilation. Ventilation is not something we've spent a great deal of time talking about. If you live in warm climes where it's hot most of the year, fans, moving the air around. We didn't talk about that, but air exchange is very important for reducing the risk of acquisition. And so, it's really basic epidemiology.
Right.
For the younger kids, it's more difficult. I think if the staff is vaccinated and masking, and the room is big enough to hold, a smaller number of students, maybe, that's going to be probably the best you can do.
Right. I think there's a question about risk of vaccine causing infertility in boys and girls. I don't think that there's any data for that. I don't know, Mark, if you...
There's no data that vaccination causes infertility. In fact, there was a large study in the UK where they went back and looked at women who were pregnant during the trial, and they compared those who got placebo to those who got vaccine, and there was no difference in fertility. So there really is no data that the vaccine causes infertility.
Right, absolutely. I think we are reaching the end of time, so we can just call it right now. But thank you so much for giving this wonderful talk. There has been a lot of concern about this topic worldwide, and we get continuous questions about that. So I'm really glad you addressed these questions so well, and also gave an excellent talk on this topic. So thank you, Mark, for giving this talk.
And if you if people want to email, you can send out my email address.
Sure.
And they can email me questions. I'd be happy to answer.
All right, thanks. We appreciate that. And thank you everyone for attending this session today. And please stay safe, and we'll see you next week. All right, take care.
Okay, thank you. Bye-bye.